Emilio, are you there?
Are we good to go?
Yep, we are.
Yes, we can start now. Hi everyone, thank you for coming in on time to the last pressure injury session today. Thank you, Emilio.
Can we start?
Yes, we can start now.
Good afternoon, everybody. Thank you for joining us for the last session of the Tissue Viability Program. Jonathan, I think you need to start recording.
Yes, it's recording.
Okay, thank you very much. So we're going to talk about burn wounds today. And one of the things that we need to be aware of is that, unfortunately, if we look at statistics, burn wounds are still quite high everywhere in the world. Depends on the region, depends on what the culture does and tells us. Fortunately enough, with a lot of education that has been going on recently, especially in Asia, burn wounds, especially in the homes because of open fires, has reduced quite a bit, but it is still a very devastating type of injury that needs a lot of care and a lot of follow-up. There are different ways that people can get burned. One of the common, unfortunately, with younger aged patients is scalds from hot liquids. Contact burns can happen anywhere, but many times this happens in the industry. Flame burns, sting burns, flesh burns, all of these have got their own etiology. However, although they are all burns, sometimes the mechanism will be totally different, and therefore the burn can show in a different way. One of the things to also remember is that the depth of the burn, the seriousness of the burn, depends on a few things. The first one is the capacity of the agent to hold that heat. If you think, for example, people who get burned and they are wearing synthetic clothes, the burning of that nylon on the skin, what is the temperature of the agent, how hot it is, the duration of contact, the transfer coefficient, and the specific heat of the conductivity of the local tissues as well. What is definitely for sure is that a burn wound doesn't happen and go away. It has got a lot of immediate but also very long-lasting repercussions. We've got this, for example, study that came out a few years ago, but shows us how devastating these burn wounds could be. Try to think about kids who have been burned and they need skin graft. The skin graft doesn't grow with the normal growth of the baby or the child, so different operations needs to happen. Think about the scar tissue formation, the contractures, and one of the important things when it comes to management of burns is not just managing the wound, but as we have talked about many times, managing the patient as a whole and also managing the family. Psychosocial support, psychiatric support sometimes is very, very important in these issues because these patients and their families don't only suffer from the wound, the burns itself, but also try to imagine how it will affect their whole living. How do we take care of burns? In the beginning, we obviously need to make sure that the patient is stabilized. We'll talk about fluid resuscitation in a few minutes. Also, understanding the initial phase is very important to wound care and how we take care of the wound. In older days, there used to be a lot of bathing of these patients. I remember we always had big baths in the entrance of the burns unit. These nowadays are not used that much because there have been certain publications suggesting and investigations suggesting that this is called sometimes like a bacterial soup and can contaminate from one wound to another. Nowadays, there are more modern approaches to that, modern approaches to different types of debridement that we talked about in previous sessions, for example, hydrosurgical debridement. The initial phase would be removing all the debris from the wound. And as you can imagine, this can take, depending on the size and the severity of the wound, this can take quite a few sessions in the operating theater. And the staged operation will take quite a few times in the first days, sometimes even weeks, to make sure that we are cleaning, that we are preparing the wound. And usually that will happen many times with different types of grafts. Grafts can be the regular grafts that we get from a donor side to a recipient side. Mesh grafts are used quite a lot, but also different type of skin banks are available in burns unit where we use cadaveric, but also there are engineered grafts that can be used. Different types of dressings. It's quite a specialist arena. We're not going to go too much into detail about that, but look about what we can do in burn cases which are not that extensive. The fourth phase is the most difficult. It's the reconstruction, as we said, of the wound, but also the rehabilitation and reintegration of the people back into society. This can take quite a long while. It's a thing that needs definitely to be done in a multidisciplinary team because we need a lot of different expertise. This brings us to one of the first polls that we have, and we're talking here about a specific thing about burns. The closest area to the damage of the heat source is hyperemia, stasis, or coagulation. Seems we are hesitant to take the poll today. I know this is not general knowledge, but give you about 5 more seconds. Okay, thank you for trying. So when we are talking about the areas or zones, what we are talking about is the Jackson's burn model, where in this type of classification, we have 3 different areas that describe the zones which are the closest to the farthest of the burn source. So the first source is the zone of coagulation. This is in the center of where the burn had happened. This leads to the immediate coagulation of the cellular proteins. Remember, when we're talking about coagulation in burns, we're not talking about blood, but we're talking about cellular proteins. So in this area, these cells have died and cannot be salvaged. The next zone, which is the zone of stasis, is where now we have an area of decreased perfusion. This is the second farthest from the source. Can be resolved, however, if we don't do the proper fluid resuscitation, control edema and infection. This can also lead to permanent cellular death. The zone which is farthest away from the heat zone is the zone of hyperemia. These are cells which have been damaged, however, can be recovered because if we do the proper resuscitation with fluid, these can recover. However, patients who are 20% or more of total body surface area, the whole body is involved, and this is why we get the suggestions that anybody who has more than 20% of the total body surface area should be immediately hospitalized in a proper burn care center. There are different ways how to describe the characteristics of burn depth. This is one example that talks about the different depths, the color of the skin, if there's blisters, etc., etc. So one of the easiest way how to do it is by looking at the different degrees of burns. So in the first degree burns, do you have the dermis, which is involved, the epidermis, or both? Any takers? Give you 5 more seconds. Okay, so thank you for participating. So when we're talking about the first degree burns, these are very superficial burns. The most common first degree burns is by means of exposure to the sun. However, it can happen also with quick contact with a heat, but also sometimes scalds. However, scalds can also go to degree 2. The skin is red. These can be very painful, and because the nerve endings are still there, and usually healing occurs within 3 to 5 days. These type of burns, you can use a cooling agent, like for example, a hydrogel dressing, which is quite good for these patients. And also we can use types of creams and ointments that are available. I remember in the old days, I think it's still quite a good for us. There's degree burn, we used to use calamine lotion. For superficial second degree burns, we have the epidermis and the superficial portion of the dermis, very common in scald injuries, and typically you will have blister formation. Again, these are quite sensitive because the nerve endings are still there. If not too extensive, these are usually treated on an outpatient basis and expected to heal within a maximum of around 3 weeks. Deep second degree burns goes down to most of the dermis, and therefore you have this more whitish coloring. They are less sensitive because now we have nerve endings which have been damaged as well, and usually these wounds will still need to be taken care of for the wound management as well as potential skin grafting. Third degree burns are full thickness burns. These are very complicated. If not taken care of properly, they can become easily infected. These are common where you have a long duration of the burn on the wound. For example, if the clothes catch fire, they will continue to burn the skin until it goes down to full tissue burns. Usually, these burns will need to be taken care by the plastics and the burn specialists. And then we have the 4th degree. Some people include this also in 3rd degree, where it goes down to the full thickness down to the bones. If you realize the degrees of burns are almost identical to the stages of pressure injuries. So if you forget the degrees of burns, remember the stages of pressure injuries, and this will help you in determining it. However, nowadays, there's quite a bit of discussion if we should look at the first, second, or third degree, or else just give a description of which level of the skin has been burned. This is taking on quite a bit because people say it is less confusing and more straightforward. And therefore, when it comes to policies and procedures, more often than not, nowadays, we're using the burn descriptions rather than the degrees. However, the degrees are still popular among many clinicians as well. We mentioned the total body surface area, how much the burn makes up of the percentage. There are different ways how to do it. One quick, easy way is to use the palm, but that is not accurate at all. And therefore, the two which are used the most are the Wallace Rule of 9 and the Lund and Broder. So for the Wallace Rule of 9, the different parts of the body are assigned a percentage. Most of the big areas are 9%. This is why we call it the Wallace Rule of 9s. In infants and children, it is a bit more complicated. And what we know is that the Wallace Rule of 9, especially when it comes to pediatric patients, it is not really that accurate. However, it is quite easy to remember and do. And usually this is the type of TBSA that is done on the field and before we take the patient to the hospital. The Lund and Broder is slightly more complicated, usually used more by burn centers and by specialists. It is more accurate than the Wallace Rule of 9, especially when it comes to pediatrics and infants. It can calculate very much better than if we're using the Wallace Rule of 9. So let's see if we were, sorry about that. Let's see if we were paying attention. Which one is considered the most reliable? Wallace Rule of 9 or Lund and Broder? Okay, we'll give you just a few more seconds. So the person who said Lund and Broder, you got it correct, as we said previously. The Wallace Rule of 9 is easier. However, it is not as accurate, and the Lund and Broder, especially if it comes to looking at calculating the TBSA in pediatric patients. One of the things that many times we need to be aware of is looking at how to take care of patients when we have non-complex burns, because obviously the complex burns go to the specialized units, and if we're not involved in the burns centers, we usually don't take care of these patients. First aid is usually obviously trying to stop the burning and trying to remove jewelry and hot clothing if it is not attached to the skin. Cooling the burn is easy because all you need to do is open a tap of cold water and let it there, leave it there for about 20 minutes. Just wetting it for a few minutes will not be enough because you need to cool the whole skin, and just a few minutes under the tap water is not efficient enough. These hydrogel and hydrogel sheets are very good in treating these superficial burns. Analgesia should be given because superficial burns, as we said, are quite painful because of the nerve ending involvement. If obviously the burns are more serious, we need to definitely refer the patient to a burn center in the ER or in the community center where we take these patients. The tetanus status should be checked and provide any immunization if it is not. Once it is established that the patient is safe, then we need to make sure that we are giving enough information and education to the patient and his or her carers on how to manage the wounds. So if a patient does not need to be admitted to the burn patients, make sure that we are following good protocols on dressing changes for these patients and management of blisters. And we will go through what needs to be done in a few slides. So if we look at the suggestions from the American Burn Society about admission of a patient, they are talking about the different degree burns and the different total body surface area because they're looking at that Jackson's burn model that we talked about. And this is why it's very important that if we come in contact with a patient that has been burned, apart from providing the first aid care, we need to take as much as possible the history and why and how the burn has happened, because this can determine if the patient is admitted or not to a specialized care unit. What is unfortunate with burns is that in extensive burns of 30% or more TBSA, it is not just the burn wound, but the whole system is affected. For example, the cardiovascular, there is shock and electrolyte imbalance. And that is why, again, not just because of the Jackson's burn model, but also because of this, that fluid resuscitation is important. There are issues, obviously, with respiratory, and unfortunately, many patients die not from the burn wounds, but from inhalation problems. Their metabolic rate is definitely a huge problem for us, as well as they become immunologically suppressed because of the extent of the wounds. And that is why when we have specialized burn centers, these are treated like an operating theater. We have not as sterile as a theater, but at least a clean area. We talked about the fluid resuscitation, and this is a specialized area of care, of course, but it's good for us to know. This is one of the most used types of formulas. Why is it so much important? Because if we give too little, as we saw with the Jackson's burn model, too little can mean that the area affected by burns continues to increase. If we give too much fluid, obviously we can drown the patient in his or her own fluids. Another thing that is not that common, but can be seen when it comes to management of severely burned patients, especially when we have blast injuries, and we have especially also in, unfortunately, war zones, that we have these escharotomies, which can be life-saving to reduce the risk of compartment syndrome. So if the patient cannot breathe because of the amount of pressure on the chest, but also on the limbs, because if there is too much pressure, obviously circulation is compromised and the patients can lose their limbs because of lack of circulation.
And it doesn't bleed like crazy.
I like Mr. Wine. Oh yeah, that's good.
Okay. That's probably enough.
That's it?
Yeah.
Now, one of the discussions about burns is about blisters. So what do you think we should do with blisters? Should we always remove the blister or not? Or maybe depends. Give you about 5 more seconds. So most of you went to depends, and that is probably the wisest reply, because we need to first look at the pros and cons. So if we leave the blister intact, leave it as it is suggested that it might encourage moist wound healing environment and acts as a natural barrier, kind of a natural dressing. The growth factors in the blister can also enhance healing. However, the fluid as well can prolong the inflammatory process. So if we aspirate or debride, the positive is that there is less chance of the wound getting problems because of the pressure. We can observe and control the wound bed better. However, it might be suggested that if we remove it, we might increase the risk of infection because now we have an open wound. So what are the recommendations? The recommendation is that debridement should be done of these blisters because they can resist function. They don't allow us to assess the wound properly. The skin on the blister is non-viable tissue. If we are using dressings, then we cannot get the dressing in contact with the wound bed. And one of the things that is suggested to leave the blister intact is if the blisters are less than 6 millimeters. So basically what is being suggested is that if it is, some people say that if it is bigger than the fingernail of the patient's little finger, then we should leave it intact. If it is bigger, then we should remove it. However, again, there are a lot of pros and cons. The suggestion to remove it mostly is that we are in control of the wound and we can dress that wound better. One of the biggest and most important complications of burn wounds is infection. This is the cause of most of the death when it comes to burn patients, especially with an extensive TBSAs. These wounds in the beginning are sterile because of the high heat, but once the temperature starts cooling down, it starts becoming colonized very quickly by microorganisms. There's a pathway then that is suggested, where it is suggested that the gram-positive bacteria are the first microorganisms that go in. However, the colonization is quite quick. And remember also that these patients, because of the extent of the burn, are quite immunocompromised, and we need to make sure that these wounds are kept clean at all time. And whenever we do a dressing in these large areas, it is done in a strict aseptic technique. Burn infections are different. So one of the first types of wound infection that we can encounter is the infection of skin that has not been debrided, and therefore the appearance of the wound becomes quickly degraded, and it is associated with bad infections. And that is why we need to make sure that proper debridement and desloughing is done. It is done extensively in this operating theater. The excised burn or graft itself can become also infected, and this also needs extensive management in these type of operating theaters. Burn wound cellulitis is quite common, where we have the infiltration of the microorganisms in the tissue surrounding the wound bed. Also, we have to make sure that we look at even the small burns, not just the big burns, to make sure that these wounds are not becoming infected. That is why some suggest that in these types of wounds, it's better to use an antimicrobial dressing so that we reduce the risk of infection prophylactically. One not very common type of infection, but you can come across, is folliculitis, where you have the inflammation of the hair follicles secondary to the trauma from the burn injury. Burn impetigo. Do you think it's infection of the follicles, loss of epithelium from a previously reepithelialized surface, or involves both? Okay, so we will see what impetigo is, which is basically, we're talking about, some people refer to it as ghosting or graft melting. These are superficial abscesses that can cause extensive disruption. We have the loss of epithelium from the previously reepithelized surface, can include also grafts, partial thickness wounds, and these need to be taken care of very extensively. We need to make sure that there is antibiotic coverage, but also the use of topical antimicrobial. One thing which can be quite devastating to a burns unit is if there are young children especially who get chickenpox, because if chickenpox starts spreading in a burns unit, it can be really, really devastating, but also looking at viral infections of the wound, such as herpes simplex. Remember, these patients are very much immunocompromised, and any addition of any type of microorganisms can be quite deadly. So how do we manage burns? So the ideal burns dressing is quite similar to any other dressing that we look at, where we have the atraumatic. It needs to be a non-adherent dressing. The dressing, the primary dressing or the secondary dressing, needs to have good absorbency. The dressing needs to have antimicrobial activity. However, here we have to be careful, because some type of antimicrobial dressings have a huge amount of antimicrobial in it, and it can cause cytotoxicity. The rule of thumb is that if the dressing is causing pain, pain is an alarm. It means the body is telling us that something is going wrong. So you need to use a dressing that is a good antimicrobial, but is not cytotoxic and can help us with the continuum of healing. Ideally should require frequent dressing changes, and we have different sizes available. So again, when it comes to dressing of burns, it is not that different from dressing other patients. It's more the technique of how we do it, because these patients are immunocompromised, but even in smaller burns, we are still looking at the same type of characteristics that we are looking in other wounds. One of the most commonly applied management of these wounds is the use of SSD cream, silver sulfadiazine cream or ointment. It is considered as an effective way to manage burns. Do you agree? or don't you? Give you a few more seconds. It is very interesting that those of you who did respond to this poll, nobody said no, so you think that SSD cream is efficient. So let us look at what should be done. First of all, we need a moist wound environment. We've talked about this when we were doing the wound bed preparation. Non-adherent, so anything that we apply on the wound should be removed easily without causing damage. We should not be changing the dressings every day because, one, it is painful, two, it is very expensive. We need sometimes, especially if they're a bigger surface area, we need to take the patients to the theater. The basic message that we need to send here is that silver sulfadiazine cream can be used maybe in superficial burns, which are very small. However, it should never be used in larger burns, even anywhere like 5 centimeters or more. Why? Remember that silver sulfadiazine cream is something that was created in the 1960s because there was a huge resistance to penicillin. Penicillin wasn't working anymore. So what they did, they introduced another antibiotic, which is sulfadiazine. The other problem with SSD creams is that within a few hours, it actually starts developing its own microorganisms. It is very difficult to apply, takes a long time to put on, and takes a long time to remove. When we remove it, we don't know if we have cleared it all, and any even microscopic specks of the cream or ointment in the wound can create more infection and inflammation. And apart from that, it is cytotoxic to a lot of the beneficial cells that we need to use for healing the wound. All the bodies that suggest guidelines will tell you that SSD creams should not be used. Even topical antibiotics, things like these type of antibiotic creams that you can find from pharmacies, these should never be used. The creams and ointments, as we said, they create their own microorganism environment. They can create more infection, more inflammation. And why we change silver sulfadiazine cream every day? Because it should actually be cleaned off not even 24 hours, but even less, because it starts creating its own pseudo eschar. One of the antimicrobials which is quite safe to use is the terms of silver dressings, safe silver dressings, because we know the activity of silver, how it works on these patients. The other thing I mentioned previously was that there are dressings which are very high in silver content, and the problem with these is that although they are great as antimicrobials, the problem is that they can become cytotoxic, and that is why some of these dressings, the patients will complain of pain within a couple of hours that we apply these dressings. So when we are choosing a silver dressing, make sure that yes, we have enough silver in it to kill the microorganisms, but also effective and efficient in helping the healing process, and also be a non-adherent dressing. Before we go into the last section, are there any questions or comments about burns? Okay, so we move on to the last section, which is a short section session going over acute wounds. So if we think about acute wounds are wounds which usually happen because of an accident or an incident. It's a break of the skin that happens suddenly rather than over a period of time, like chronic wounds. An acute wounds usually heals at the normal rate of healing. However, even acute wounds can become infected, and even acute wounds can become stalled. This happens because the wound is not covered properly, or the wound is not treated properly, and it becomes complicated. But remember, an acute wound cannot become chronic. Chronicity happens because of etiology. An acute wound, yes, can become infected. We have also studies showing us that even acute wounds can be affected by biofilm. Acute wounds can become stalled in the inflammatory process. They mimic the wound chronicity, but at the end of the day, we are talking about different wounds. There are different causes of acute wounds. Some of them may be planned. For example, if the patient is having a surgery, but when we're talking about acute wounds, we're usually talking about accidents and incidents of trauma. So these are the most common types of wounds, where we have avulsion wounds, which we have shearing forces, lacerated wounds, where we have the jagged, irregular edges. Contusions happens because of blunt force trauma. Incised wounds, where we have cuts. Burn wounds. We talked about puncture wounds, can be because of a sharp object or because of a bullet. And abrasions, where we have the superficial layer of tissue removed. So these are more examples here of acute wounds. These type of wounds can be also quite problematic, and that is therefore why when we see these types of acute wounds, we need to do a proper assessment and history taking, and making sure that these wounds are kept clean. These wounds are kept covered to promote that moist wound healing environment. Always think about if the patients are covered by tetanus, because one of the worst deaths that you can ever see in your life is patients dying because of lack of tetanus covering. If we're talking about different types of healing, secondary intention refers to suturing, refers to granulation, or suturing after infection. Give 5 more seconds. Okay, so let's look at the different types of healing that we can have. So primary intention is where the wound edges are. We are able to close these wounds by means of sutures or clips or whatever type of management you can use. Nowadays, we can use glues as well, which are quite effective in smaller wounds. Secondary intention, when we have the edges that cannot be approximated, we have wounds which are quite big, and this is where we start differentiating between a wound, which is an incision, or an excision. So if you have a bigger wound, obviously you need to let it heal by granulation, and sometimes it is closed up at the end by means of grafting. Delayed primary or tertiary is where we have a problem with the wound. We leave it open to heal. For example, resolve infection, and then close it again later on. The way how these decisions are taken, there are examples of the guidelines, and one of the guidelines that suggests is the reconstructive ladder. You can find it as the reconstructive elevator as well, where it looks at how simple or how complex the wound is and gives suggestions of what type of closures these need to happen. Obviously, this is something that surgeons go through in their education to remember what needs to be done.
Wound closure is accomplished one of three ways: by primary intention, secondary intention, or tertiary intention, also known as delayed primary closure. Let's explore these various types of wound healing by clicking on the tabs. The simplest and fastest type of wound closure is referred to as healing by primary intention. Primary intention involves reepithelialization, in which the skin's outer layer grows closed. Cells grow in from the margins of the wound and out from epithelial cells lining the hair follicles and sweat glands. Wounds such as abrasions that involve only the epidermis heal by primary intention. In addition, deeper wounds, such as surgical wounds with well-approximated edges, heal by primary intention. In these types of wounds, the edges are brought together using sutures or adhesive strips. Wounds that close by primary intention are associated with minimal tissue loss. Secondary intention occurs when there is a greater degree of tissue loss, or with surgical wounds whose edges cannot be easily brought back together. Wounds that heal by secondary intention have a higher risk of infection, longer healing times, and result in visible scarring. A dehisced surgical wound is an example of a wound that heals by secondary intention. Occasionally, wounds are closed by delayed primary intention. This is a combination of healing by primary and secondary closure, also called healing by tertiary intention. If a wound is contaminated, this technique may be used to decrease the risk of infection. The wound is initially cleansed and observed for several days. Once the wound appears clean, it is surgically closed. In general, delayed surgical closure is used on surgical wounds or lacerations once they are believed to be free of contamination.
One of the obvious most common types of wounds that you can come about is surgical wounds, and again we are not going into too much detail because it's quite a specialist area. And one of the most important things that needs to be understood for the management both of pre, peri, and post-op is the classification of the wound. You can find these type of classifications from the CDC website from the US, which gives us quite an in-depth idea of how these wounds are managed. So as we said, there are two different types of surgical wounds. One is an incision where we have a clean cut, or else we have an excision like when we are removing a cyst or other tissue. Obviously, the goal is the same, to heal the wound rapidly without complications and get the affected area to the best level of function. We hinted previously about what techniques can be used to heal surgical wounds. Sutures are the most common, but again, if we're talking about sutures, it's quite an extensive subject, depends on the type of suture you are using. For example, is it silk, is it Prolene, is it Kergat? And even the techniques of suturing can be very different. You have the subcuticular, you have the continuous, etc. Depends on the surgeon, depends on the wound, depends on the extension of the wound, and also depends on the area. So sutures in the face would be different, for example, than sutures in the abdomen. Another option is staples. These medical staples are made from the special method. It's not, we can't use obviously the normal staples. It is suggested that these provide a stronger closure than wood sutures. The skin strips can be used when we have a small incision, or also to support more a wound which has been previously sutured. And tissue adhesives or skin adhesives are nowadays a commonplace when it comes to closing small areas. What are the suggestions for prevention of surgical site incision? One of the biggest questions that we always get asked is, when should we change the dressing? Unfortunately, we know that many clinicians prefer to open the dressing first day post-op to see what is happening. This is not what is suggested by international guidelines. They suggest that it is kept intact for at least the first 48 hours. If we need to remove before 48 hours, we have to make sure that we are using a proper aseptic technique, and if we need to clean or cleanse or irrigate, we use sterile solution. If there are any signs or symptoms of problems occurring with the suture line, obviously we need to contact the surgeon and or the tissue viability services. So if we're looking at surgical site infection, again, referring to the CDC, and the CDC differentiates between superficial, deep, and organ. So superficial is where we have only the skin and the subcutaneous tissue involved. Deep incision include tissues and might include fascia and muscle, and organ space where we have the body cavity that was open and manipulated during the surgery, which is affected. We mentioned during the session of burns, we mentioned skin grafts, and skin grafts are quite commonly used in these types of injuries. So a skin graft is where we use a dermatome, which looks almost like a potato peeler. You can have a manual dermatome or an electric dermatome, where the epidermis and dermis are completely separated from their blood supply, which is the donor site, and then transplanted to the affected area, which is called the recipient site. The management of both wounds can be quite different, but both require to have a non-adherent atraumatic dressing with moist wound healing environment, and usually these are kept in place without disrupting the dressing for at least 5, some even suggest up to 10 days. Different types of grafts that we mentioned previously, so the autograft from the same person, allografts that come from another person, and we're talking here also about cadaveric skin banks, which can be found in the big burn theaters. Then there's also a differentiating if it is a partial thickness or a full thickness. So a partial thickness involves the epidermis and part of the dermis, while a full thickness goes down to the dermis. Again, this is the decision of the surgeon according to the type of wound he or her is managing. One technique that is used quite a few times is meshing, where the graft that is taken is meshed, because then we can stretch the skin and it covers more areas. Epithelialization starts happening inside these tiny holes, and it also allows, if there's any exudate coming out, allows for drainage as well. These are some examples of the skin substitutes that you can find out there. Nowadays, there's quite a few of them. Again, depends on the availability and depends on the surgeon who decides what type of biological skin substitutes can be used. Last poll question: do skin grafts maintain their own blood supply, true or not? I think we gave you that answer already. Give you 5 more seconds. Okay, so remember what we said about skin graft. The skin graft is removed from one area of the body and then transplanted into another area. So the answer to that is no. Skin grafts do not maintain their own blood supply. What maintains their own blood supply is a flap, because it is not detached from the original position, and the circulation is left intact. This also applies if you see the picture on the left, might remind you when we were talking about skin tears, where we use the flap to cover the wound as well. Depends, again, on the area, depends on the surgeon to make the decision if it should be a graft or a flap. So this brings us to the end of our session. I hope you found the sessions informative. Again, if you need any more information, if you have any questions, please do not hesitate to contact us. We will be more than happy to help you. Thank you very much. Anything to add, Jonathan?
No, I think we're good. Thank you for having us for so many sessions, Mr. Maggie. 8 sessions, I think.
Yeah.
8 long sessions. Yeah, so thank you very much. As Emilio has mentioned, any questions, please feel free to reach out to us by email or WhatsApp. Yeah, and we'll be ready to assist. Whether is it anything that we've gone through in the past 8 sessions, or is it with regards to any of our own products as well. Yep.
Thank you for the sessions.
All right. You have
It's
anything
been
else
very
to add?
interactive. I think that will be all, but thank you. And thank you
very
everybody for
much.
attending.
Thank you. Take care.
Thank you.
Right,
Take
cheers,
care.
Thank you. Bye.
Bye-bye.